Good afternoon to one and all present here. It's my pleasure to introduce my mentor, Dr. Ravi Samuel. Dr. Ravi Samuel strongly believes the secret of success is to stay humble no matter what. One must never let pride overtake. You can show your might in your performance, but not in your attitude towards others, is his motto. He puts in about 16 hours of work every day, spends weekends pursuing his hobbies, practicing religion, and rejuvenating himself. Dr. Ravi Samuel has a postgraduate certificate in applied research methodology from Thames Valley University, London. He also has MPhil social work from Loyola College, Chennai. He has a doctorate in medical and psychiatric social work from Madras University. He is a consultant psychotherapist, has a clinical experience of 28 years in India and 1 year in UK. He is an associate member of Indian Psychiatric Society. He has been trained in cognitive behavioral therapy by Mr. Alan Davidson, cognitive behavior therapist at Department of Clinical Neurology, Institute of Neurology, National Hospital for Neurology and Neurosurgery, Queen Square, London. We would all be very eager now to meet and greet Dr. Ravi Samuel. I'm sure we will have a lot to take away from this session. Over to you, Doctor.
Thank you very much for that very nice introduction. Sorry, I always start laughing when someone introduces me. Now and then I'll take a small break because there are a lot of people waiting in the waiting room. So just trying to invite them inside. All right. See, cognitive behavior therapy, all of you must be having some understanding about it because I'm at the basic level. I'm going a little higher than that. So I presume all of you know what cognitive therapy is, behavior therapy is. CBT is nothing but a mix of all the therapies. The advantages of CBT is it gives you complete freedom to operate, unlike other therapies. What I learned through the books and training in sufficient enough for me to practice. So I had to reinvent.
Sir, can you little bit louder, please? Because we are not able to hear clearly.
Can all of you hear? Are you here now?
Yes, sir. But if we can request everyone to go on mute, I think that will also help.
So you can mute everyone from your side.
Right. Right. So basically, I had to learn lots of clinical aspects. If you learn CBT and apply it just like you have learned, you will find lots of roadblocks, patients not coming back to you, patients not complying with the homework assignments, patients not able to understand the nature of therapy because patients come to get guidance from us. They like to hear what they need to do. But the nature of CBT is that you ask them what is the best thing to do. And you are more kind of prescriptive. I don't know, sadly everything is rolling. Oh. So basically in CBT, there are lots of clinical aspects which are very essential, which you need to know to have a successful practice. In your assessment, you will be evaluating the cognition of the patient, the behavior of the patient, the physiological aspects of the patient, and the mood. Whereas in a clinical setting, those alone are not sufficient. You need to have a rough idea about the personality of the patient. What kind of a personality? Are they very, are they a very outgoing person? Personality problem like a borderline personality problem. So you need to associate the symptoms to the personality. Imagine you get someone with lots of adjustmental problems. You may need to like to see their arm because you will see cut marks, which will be indicative of a personality disorder, not one single cut. If there are series of cuts, then it will give us a clue that the person is lonely, the person is very volatile and can indulge in self-injurious behavior. That you cannot directly ask, obviously. You have to kind of gently have a look at their arm when they are moving their arms, when they are trying to move about. So personality evaluation in a very gentle, subtle way is very important. Similarly, the family situation, you have to know what is the personality, then the family background of the person. Is he a married person? How supportive is the wife or husband? What kind of children they have? What kind of family dynamics that are operating? To give you an example, if the father is not a very caring person towards the wife, invariably the children will not be very caring. So the lady would end up feeling very lonely when she is having an illness. So these kind of family dynamics we need to know. Similarly, a person who has come alone is likely to have less of emotional support than someone who comes with many number of people. Also, there are clinical dynamics in it. That is, I'll give you an example. A patient used to come and report, I'm feeling very lonely, doctor. There is nobody for me. No one is helping me. Nobody is there. Then one day I casually asked, out of a doubt, these things kind of randomly happen, not that we are wise enough. Who brought you to the hospital? She said, my mother, my sister, and my sister's husband. So 3 people brought you to who normally brings you to my clinic? She said, these 3 people regularly come. So there is a cognitive distortion. She is not able to acknowledge the fact that there are 3 people who are setting aside their schedule, routine, and coming and attending to her. Also, you need to look at the circumstances of the family. Is there a recent death? Then you have to see, normally patients don't tell us everything. Number one, they don't know what to say. That's my understanding, because they are confused exactly what is the psychotherapist, what will he do, and all that. The second thing is, of course, you have to use your clinical judgment. You have to use your clinical acumen to see if the whole family looks a bit low, not normal. Then you should guess that something must have gone wrong in the family. Some death or loss or some major catastrophe or property dispute like that. The last thing is, you should always check for psychiatric condition. Always ask this question, are you seeing a psychiatrist? Are you on medication? Because many patients come to us to find alternate for psychiatric medication, which is not acceptable at all. In clinical psychotherapy, we don't do that. We have to discourage them from pursuing psychotherapy as a parallel to medication. You have to tell them CBT is done as an adjunct to medication. You please continue your medication. Only then I'm happy to continue the psychotherapy. Otherwise, what will happen is that the psychiatrist will find that this is a very big offense that you're doing. It'll bring displeasure to the psychiatrist community that you're discouraging people from taking medicines. Also, another vital point you have to make clear is you must try to communicate with the psychiatrist so that there is no false information being conveyed to the psychiatrist. Many patients in my case have gone to the psychiatrist and said, Dr. Ravi says we need not continue the medication, we can just do psychotherapy. Since they know me, since they know how I operate, they challenge the patient. Ravi, doctor will not say like that. I think you are misrepresenting. So you should have some rapport with the psychiatrist better so that there is no misrepresentation. The second aspect is, do I apply cognitive therapy? Do I apply behavior therapy? Do I just give some general advice? As I always tell my students, your advice should not be one that they will hear at home or through their friends. So that means you have to start your professional work from the moment a patient walks in. So you have to choose, what am I going to do at a given point? Imagine right now we are having lots of patients with, of course, anxiety. What is the anxiety? Doctor, I'm feeling very anxious, doctor. My neighbor has got, so many people are coming and going. I'm so scared I might get coronavirus. I'm feeling extremely nervous, doctor. What do I do? I'm not able to sleep. I'm not able to do my work. I'm completely disabled. Right. Now you find there is a faulty thought process. You find the mood is altered and the behavior is that of someone in extreme stress. There is physical manifestation for sweating, nervousness, palpitation. So you're at a loss. Do I address his cognition? Do I tell him that the fear is irrational? Or do I intervene at the behavioral level and make him do things at home? Or do I intervene at the physical level of bringing down the anxiety through relaxation methods or through breathing exercises or through other hypnotic techniques? Then are we going to give general advice? Be with your family, talk to them, kind of very generic things. My advice is you always focus on the physical aspects of a person because that's what gives the highest level of distress to a person. They are feeling anxious, they are feeling very nervous, palpitation, they are not able to sit. When they sit, they want to stand. When they stand, they want to sit. When they sit, they want to walk. So it's a kind of very distressing situation. So you try to intervene at that level through very simple Jacobson's relaxation exercise. You teach them that, then ask the patient to do it at home. What happens is you are empowering them with something. You are empowering them with a tool which will help them to bring some control. over their physical symptoms. So once there is some improvement in the physical symptom, see, if someone does relaxation exercise, how much ever they are anxious, within about 3-4 days, their anxiety levels will come down. So they start feeling little better. Oh, doctor taught me this exercise. Though it is a bit cumbersome to keep doing it every day 4 times, but it is helping me. So let me do this. Then you teach them breathing exercise, just deep breathing exercises. They try to do it. Then if you keep enforcing it, it becomes a habit. And then what happens is they start feeling, see, breathing exercise just supplies more oxygen to the body. More oxygen to the heart means more oxygen to the brain. So there is no way they will not feel good about the breathing exercise. Most people smoke for this breathing exercise, affecting their lungs. A simple breathing exercise would get them as much results as smoking. Thankfully, I don't smoke. But for those who smoke, it's extremely disastrous consequences. So start with the physical exercise, the Jacobsons, the breathing. Then move on to the behavioral aspects. That would be enabling them to have a routine. Just first try to put people to sleep. What I mean by that is, if they are sleeping at a reasonable time, say between 9 and 11, their circadian rhythm will get normalized. So automatically they'll start feeling good. For most of the mental health problems, sleep is the casualty. So the first thing you should do is try to normalize the sleep. How would you normalize the sleep? Give them a time to go to bed. The second aspect is, you have to tell them, even if you're not sleeping, if you're lying in bed with your spine being flat, it is good rest for you. It's about half the rest the body can get. If you sleep, then it's 100%. Because not all people go to bed by 9:30 in the world. So you have to kind of gently encourage them to sleep little in tune with the biological nature's clock. If that goes wrong, then the circadian rhythm goes wrong. If you normalize the sleep, you will reverse many of the symptoms. You will neutralize many of the symptoms. Patient would think, I'm just sleeping, nothing fantastic I'm doing, but the symptoms would improve. And the funny thing about psychotherapy is, patient will do all the work, you will get all the credit. They'll say, I went to Ravi Samuel, I'm far better now. So the doctors will also wonder, what on earth is Ravi doing? So in CBT, you just tell them the right thing at the right moment, they do, and you get the credit. Then the last thing should be the cognitive aspects. Changing people's cognition is not an easy thing. If I try to change your cognitions, you're not going to take it very easily. If I ask all of you to go to bed today by 9:30, none of you will, except one or two. So changing our cognition is the most difficult one. So that you pursue after the patient gains certain level of improvements, because at that time their faith over the therapy would be very high and their compliance would be very high. I'm in private practice, so obviously if they are coming back, they have benefited or they are positive about benefiting, so that's why they keep coming. So like that, we have to infer from the patients based on their complaints to the therapy. Many psychologists social workers complain to me, sir, patients திரும்பி வரவே மாட்டேங்கிறாங்க, முதல் நாள் வராங்க அப்புறம் வர மாட்டேங்கிறாங்க, அவங்களுக்கு இந்த சைக்கோதெரபி பத்தி தெரிய மாட்டேங்குது. I tell you, ladies and gentlemen, in your evaluation you have not impressed them that you are going to deliver. They may not come back. நிறைய கேள்வி கேட்டாரு, எனக்கு என்ன பிரச்சனை, எங்க அம்மா என்ன பண்றாங்க, எங்க அப்பா என்ன பண்றாங்கன்னு கேட்டாரு. அதுக்கப்புறம் ஒன்னும் சொல்லல, ரெகுலரா செஷனுக்கு வாங்கன்னு சொல்லிட்டாரு. So at the end of the evaluation on day 1, you should either start some breathing exercise or Jacobson's exercise, or give them a plan of action. First, I will be dealing with your physical symptoms. Once I reduce some of it, I would be focusing on your routine. The more you engage in different activities, the better for you. Then you will start feeling good about yourself, and then we can address those negative cognition. Then the patient will be very happy. Okay, doctor has a plan, and that plan sounds pretty reasonable to me, and he is able to justify what he is saying. So I follow the plan. Right. This is a very important slide for those who treat OCD patients. Right. Some of the do's and don'ts: never reassure your OCD patients. You'll be all right from OCD. No, these thoughts are just provoking your tension, anxiety. Don't worry about it. So never reassure your patients, because if you start this, then they will come to you again and again and again and again and again and again, that at one point you lose your patients, because you are no different from the family members, because the family members lost their patients, and at one point you will lose your patients. So never reassure them. When they report of problems, you're a professional. You're not there to reassure. You're there to reduce the OCD, not to make them feel comfortable at the present. Second is, do not try to solve all the problems in one session. I hear lots of senior therapists having marathon sessions like 2.5 hours, 3 hours, 4 hours. Never do a session beyond 1 hour, however important, however grave the situation is. Take a break and ask them to come back for another session. So you can take a break in between and have about 2 sessions maximum. Beyond that, you should not go. But in rare conditions, we may have to do. There are patients who fly from Dubai and Middle East just for therapy. They come in the morning, leave in the night. So for them, I do some extended sessions. Apart from that, it's better not to do such trying to solve all their problems. So for the first thing you should tell them is, first I will do evaluation, then I will handle the physical symptoms, then the behavioral, then the cognitive. This is a process. This is a process-oriented approach. This is going to take about 6 months, 3 months, roughly about 3 to 6 months, depending on how well you're able to do the exercises, how well your brain reacts to the suggestions. Then lay the rules for answering. Sometimes you may be caught up in answering OCD patients. So during such time, the rule that I give is, I will answer only 3 times. Beyond that, I will not answer. So I make it as a rule, and I will not answer. Even if they come and stand and beg me to answer, I will not answer. I'll tell them, I have answered you 3 times, no more. That's the end of it. So what you are trying to do here is not be trying to be rude, of course. You are trying to enforce a subliminal message that I can also be very firm like doctor is. எவ்வளவு கேட்டாலும் இவர் சொல்ல மாட்டாரே ஒண்ணுமே. So இதே மாதிரி நான் கூட இருக்கலாமே. Maybe others are also ignoring me just like this. So like that you are teaching something. Right. Coming to the management of OCD, because there are a lot of people who have difficulty with this, and I get lots of OCD patients. So first thing you do is reduce their overall anxiety as to how you would do with an anxiety patient. OCD or anxiety, it's all the same. So you just reduce the anxiety. The second thing you need to do is, some of the thoughts would be extremely distressing. I used to get a singer who used to get a thought, a very senior singer, will I have sex with my son? And that used to make her cringe and feel so distressed. So I try to bifurcate. Your normal thoughts are different. OCD thoughts are different. OCD is like a bully which tries to irritate you and make you anxious. So please do not take it as your own thought. It is an illness-produced thought. Then teach them the cognitive exercises, behavioral exercises, and develop strategies that you would have already read in the textbooks, response prevention and all that. Right. The other frequently seen are those for marital counseling. Always authorize representation. You know, normally the husband will go and say, the doctor also agreed with me that you are very emotional and you don't behave rationally. Then the wife will be very upset. Why did the doctor say like that? Am I that bad? Like that. So sometimes, or not sometimes, many times, husband or wife will misrepresent you. So you always tell them, if I am represented in any manner by your partner, come and cross-check with me. Because all sorts of things I have heard. Doctor says, உன் கூட வாழ்றது ரொம்ப கஷ்டமா அவரே சொல்றாரு, which I never said. So things like that can happen. Second is, never find problems only with the husband or a wife, even if it is so. You try to balance it. Find something with the other person which they can improve, like being patient or being more emotionally receptive, so that one person does not feel cornered in marital therapy, marital counseling. Otherwise, it will become a very bad scene. Already they'll suffer from low self-esteem and lots of misgivings. Then this will happen that doctor also feels I am at fault. So always try to balance it. Both of you have to change. You have to change in these many things, and the other person also has to change in these many things. So like that, you need to balance it. The third, you have to present the problem in a non-threatening manner, because some of the problems can be extremely severe, intense. For example, sexual issues. If one party is not sexually interested at all, you have to handle it very carefully and gently, because normally the one who is interested in sex will be extremely distressed. The one who is not interested will also be extremely distressed, because she is being constantly approached sexually. So you have to present the problem in a nice manner. You have to present the problem in a way that it does not threaten their personalities. Prioritize the issues. They may come with a host of problems. So you need to prioritize what need to be addressed first, what need to be taken later. Analyze the problems very carefully. You know, sometimes we have to take time outside the clinic hours, having jotted down all the notes. We have to sit and analyze. Could this be like this? Are they being misrepresented? you have to look at it from different angles. In psychodynamic psychotherapy, they teach us when a husband or wife says, or even a patient says something about the family, you have to cross check whether the opposite could be true. If the husband comes and says, my wife is harassing me, doctor, the opposite could be true. So you have to basically think a lot. And CBT is very much dependent on your thought process. If you get a gay couple or a lesbian couple, what you think about the couple matters a lot when you do the therapy. Somewhere the bias will come out of your mouth and you will cut a sorry figure if you're dealing with foreign patients. If you're dealing with patients from the US, from the Europe, you will say something that they will catch that you're against gay LGBT group. So never let your personal bias come into the therapy. The last thing is develop activities for the couple. Make them jointly do things. Make them jointly see self-esteem videos. Make them jointly do self-esteem exercises, or even sitting and discussing about common topics and drawing conclusions where there are options to record both husband's opinion and wife's opinion. So it's very important we give exercises, activities which are inclusive of each one's participation. Right. So with those words, I thank you very much, ladies and gentlemen. We have 3 more minutes. Quickly, we can have some question and answers. Last time I found that we can get back to the forum if we go and re-enter again. So we will try that option also if there are.
Yes, sir. We can do that
Yes,
for
sir.
another
Yes, sir.
20 minutes.
And,
Yes, sir.
And one thing. Today is Sri Priya's daughter's birthday. So screen, we can all wish her a happy birthday.
Happy birthday.
Happy birthday.
Happy birthday.
Happy birthday to you.
She has not.
Not me. Is your daughter around?
Yeah, she's around.
What's her name?
No, she's
What's her
Ananya.
name?
Ananya.
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 Happy birthday, Ananya.
Yeah, I'll convey that to her. She's on another meeting, school
Okay,
meeting.
okay, okay.
Greetings.
Thank you so much, doctor. It's so nice of you.
Welcome. Anyone else celebrating their birthday or anything, please let me know. Because birthday is such a special occasion, isn't it? Right. Any questions? Any reflections? Any feedback?
Yes,
Sir,
doctor.
we are having question.
Yeah, go ahead.
Sorry, this is Sindhuja, doctor. I was just reflecting on the whole address the physical first, then the behavioral, then the cognitive bit.
Yeah.
A couple of people, or at least one person in particular, when I'm trying to nudge them to do the physical exercises, the relaxation or breathing exercise,
Yeah.
they seem to lack the motivation to even get out of the bed, or they've not taken a bath for 15 days. They just, I mean, there are too many other challenges around making them even just get out of the bed and go to the bathroom. So I was wondering if in such cases where maybe the cognitive change, the thought process around it will influence their ability to change their behaviors or the other things. What's your advice, sir?
Right. If someone is not taking bath for that many days, the first obvious that comes in our mind is are they on the second thing is, are they taking antidepressants?
Yes, they are. Yes.
If they are doing it, then probably the dosage is not sufficient enough. You may have
Okay.
to talk to the doctor about it.
Okay.
coming to this issue of they not complying, most of them will not. That's one aspect I have seen here in India, may not do. So what you can do probably is call them to your clinic and do the exercise yourself personally